Hi everybody and welcome to our module on penicillins. Shown on the screen is the basic chemical structure of a penicillin antibiotic. It's very low yield to memorize this structure for the USMLE Step 1 exam, but I show this to you now so that you can understand what makes penicillins unique and you can understand where the names of the different antibiotics come from. So the first key characteristic of a penicillin is the presence of a beta-lactam ring. That's this structure in the middle of the molecule. Beta-lactam rings are found in a number of different classes of antibiotics. They're found in all the penicillins, but they're also found in the carbapenems, in aztreonam, and in the cephalosporins. And I'll talk about these other beta-lactam antibiotics in another video. The second important component of a penicillin molecule is the presence of a thiazolidine ring. This is only found in penicillins. So when you have a beta-lactam ring next to a thiazolidine ring, like what I'm circling on the screen, then that structure is a penicillin. The other important feature of a penicillin antibiotic is the side chain, denoted by this letter R here. The side chains vary in the different subtypes of penicillin, and that's what makes each of them unique. I'm going to spend a few slides now discussing how penicillin works against bacteria, and if you understand the mechanism of action of penicillin, then you understand the mechanism of action of all beta-lactam antibiotics because they all work the same way. So bacteria are constantly breaking down and remaking their cell wall. The cell wall is not a static structure, it's constantly in flux. And bacteria have important enzymes called transpeptidases which cross-link the peptidoglycan in the cell walls, and they do this by binding to alanine residues. Recall that alanine is an amino acid, and there are alanine residues that transpeptidases bind to and cross-link in order to make the cell wall secure. Here's a picture showing how bacteria cross-link their cell wall. So these alternating green structures here are the NAM and NAG backbone of the peptidoglycan cell walls. Sticking out from those backbones are a series of peptide side chains. The last two amino acids in the peptide side chains are always two alanine molecules. What will happen as bacteria build their cell wall is that they will cross-link those side chains. So if you look at the drawing at the bottom of the screen, you can see that this side chain has been cross-linked to the other one, and this makes the cell wall functional. The enzymes that perform this cross-linking process are called transpeptidases. They are also called penicillin binding proteins, because they are the proteins that penicillin antibiotics bind to. What these enzymes do is bind to the alanine residues in the cell wall, like what I'm circling with my pen. They then pop out one of the alanine amino acids and they cross-link and make a connection between a lysine and an alanine molecule, and that's what's shown at the bottom of the screen. There is a lysine connected to an alanine, and now the cell wall has been effectively cross-linked. So the key points I've highlighted at the top of the screen, these are what you want to remember about the mechanism of action of these transpeptidases, and the way they work is that they bind alanine residues and they link lysine to alanine residues to cross-link the cell wall. Once you understand that, it's very easy to understand how penicillin works. It binds to transpeptidase enzymes. As I told you before, these enzymes are also called penicillin binding proteins. The reason it can bind to these enzymes and inhibit their action is because penicillin mimics the two alanine amino acids at the end of the peptide chain. You will see this written in textbooks as stating that penicillin mimics the D-alanyl D-alanine residues at the end of the peptides. What this means is that penicillin mimics the two alanine amino acids. The letter D is denoted because these amino acids in bacteria are in the D configuration, in contrast to human amino acids which are in the L configuration. Once penicillin binds to the transpeptidase, it inactivates the enzyme. This means that the rate of breakdown of the cell wall will become greater than wall creation, and this leads to autolysis of the bacterial cell. The enzymes that hydrolyze the cell wall continue to work, and therefore the bacteria basically kills itself. This leads to cell death, and therefore penicillin antibiotics are bactericidal. And if you understand this mechanism, you understand the mechanism of all beta-lactam antibiotics because they all work the same way. Here's a picture just to make this very clear. These are penicillin molecules. They bind to the transpeptidase, and once they are bound, the transpeptidase cannot link more alanine molecules together and cannot cross-link the cell wall. Here's a picture showing you the chemical configuration of the D-ala-D-ala terminus of the peptides in bacterial cell walls, and you can see that the chemical configuration is very similar to that of penicillin. That's why penicillin can bind the transpeptidases. Those enzymes are intending to bind this structure here, but instead they bind the penicillin structure, which looks very similar. Now we'll begin our discussion of specific types of penicillin antibiotics, and I'll start by discussing the so-called natural penicillins. These drugs get their name because they are similar to penicillins found in nature. Penicillins are produced by some fungi. That's how these drugs were initially discovered. The two natural penicillins are penicillin G and penicillin VK. Penicillin G can be given IM or IV. Penicillin VK can be given orally. And a special feature of these drugs has to do with the gout drug probenecid. Probenecid inhibits the renal secretion of the natural penicillin, so it can sometimes be co-administered with natural penicillins, and it will boost the penicillin levels if you need to achieve very high drug levels to treat an infection. The natural penicillins have a very narrow spectrum of activity. We'll talk about this in detail in a few slides. The reason that these drugs aren't effective against many bacteria is because there are a number of common resistance mechanisms that bacteria have developed. One of these is modification of the penicillin binding proteins. Many bacteria modify these proteins, often via genetic mutations, and that leads to resistance. For example, Strep pneumonia is often resistant to the natural penicillins, and that's because this bacteria often produces altered penicillin binding proteins. A second mechanism of resistance is reduced bacterial cell penetration of the drug. Most gram-negative bacteria display poor penetration of the natural penicillins. In general, gram-negative bacteria are more difficult to treat with antibiotics than gram-positive bacteria. That's because gram-negative bacteria have protection by an outer membrane. In addition, there are porins found in gram-negative bacteria. These are proteins that transport nutrients and waste, and they allow some antibiotics to get into the cell. However, bacteria can also decrease the number of porin channels, and this once again reduces bacterial cell penetration to many drugs. And then a final mechanism of resistance to the natural penicillins, one that is very important for you to understand, is the presence of beta-lactamase enzymes. Beta-lactamase enzymes are a family of bacterial enzymes. There are lots of different beta-lactamase enzymes. In some cases, they're referred to as a penicillinase. All of these enzymes can degrade beta-lactam compounds. They can break down penicillin G and VK. They can also degrade some of the other penicillins we'll talk about in this video, and they can also degrade some cephalosporins. Important bacteria that often use beta-lactamase enzymes for resistance against antibiotics include many gram-negative bacteria and also Staphylococcus aureus. In gram-negative bacteria that produce beta-lactamase enzymes, the enzymes can be found in the periplasm. On the right side of the screen is a drawing of the cell wall of a gram-negative bacteria. Recall that gram-negative bugs have an outer membrane followed by a periplasmic space followed by an inner membrane. It is in this periplasmic space or periplasm that you can find beta-lactamase enzymes in gram-negative bacteria. For gram-positive bacteria that produce beta-lactamase enzymes like Staph aureus, there is no periplasm, therefore the enzyme must be secreted into the extracellular space. For this reason, gram-positive bacteria that produce beta-lactamase enzymes generally produce more of the enzyme than gram-negative bugs because they must secrete it into the extracellular space. There are drugs that inhibit bacterial beta-lactamase enzymes. These drugs include clavulanic acid and sulbactam and tazobactam. They have little or no effect when they're used alone. However, they are often added to penicillins to expand coverage. We'll talk later in this video about how these drugs are added to the aminopenicillins and the antistaphylococcal penicillins in order to expand the spectrum of activity. Back to our discussion of the natural penicillins, penicillin G and VK, let's talk about the clinical uses of these antibiotics. In general, the natural penicillins have a narrow spectrum, and there are only a few specific modern uses for these drugs. When the natural penicillins were first developed, they had very good activity against gram-positive bacteria. However, over the years, many bacteria have developed resistance. In the modern era, they're still used to treat a couple of gram-positive infections. One of those is strep pyogenes, which causes strep throat. Another one is actinomyces, which is a gram-positive anaerobe found in the mouth. The natural penicillins are the treatment of choice for syphilis, which is caused by the spirochete treponema pallidum. And then finally, there are some rare uses of the natural penicillins which only occur in susceptible isolates. There are some strains of Neisseria and some of strep pneumonia that are sensitive to the natural penicillins, and these drugs can be used. Now, you would never use a natural penicillin for initial therapy in a patient with meningitis or pneumonia where you don't know the bacteria that's causing the infection and the sensitivity. However, once the bacteria has been isolated and determined to be sensitive to penicillin, in some cases, the treatment is switched over to penicillin. Now let's talk about some of the adverse effects of penicillins. Penicillins commonly lead to a hypersensitivity or allergic reaction. You will meet many patients on your clinical rotation who are allergic to penicillin. And I talk about hypersensitivity reactions in detail in a video in the immunology section, but by way of review, the first exposure to the drug leads to sensitization in certain individuals. The second exposure leads to a hypersensitivity reaction, and the symptoms of the reaction resolve on stopping the drug. Penicillin can cause an acute or immediate hypersensitivity reaction. This is a type 1 IgE-mediated hypersensitivity reaction. It usually occurs within 1 hour of taking the drug in a susceptible patient. The drug leads to histamine release, which can cause itching and urticaria. This is a picture of urticaria or hives shown on the screen here. In addition, this can lead to bronchospasm and anaphylactic shock and can potentially be life-threatening. Luckily, this complication of penicillin therapy is very rare. A much more common allergic reaction to penicillin is development of a maculopapular rash. This is classified as a non-immediate reaction in contrast with the immediate reaction I talked about in the last slide. This is more common with the aminopenicillins, which we'll talk about later in this video, although it can happen in response to natural penicillins. It consists of a rash that is maculopapular, it can be itchy or sometimes non-pruritic, and importantly, there is an absence of systemic signs like fever and wheezing and joint pain. There is only a rash. This typically occurs days or weeks after starting the drug, and this is a type 4 T-cell mediated mechanism of hypersensitivity. And if you want to read more about this, you can find some details in this review article I've listed at the bottom of the screen. For reasons that are poorly understood, the development of a maculopapular rash is more common in patients with a viral infection. The classic scenario where this occurs is in the setting of Epstein-Barr virus pharyngitis. The pharyngitis of this viral infection often looks similar to strep throat, so oftentimes amoxicillin is given to treat the strep throat. This leads to development of a maculopapular rash. The reason that this rash occurs more commonly in the setting of a viral infection is not well understood. Rarely, patients can develop a more severe skin reaction to a penicillin. One of these is called Stevens-Johnson syndrome. This consists of fever and necrosis of the skin and sloughing of the skin. The skin breaks down at the dermal-epidermal junction. This can lead to vesicles and blisters. This is a picture on the screen of a man with the Stevens-Johnson syndrome. If this skin reaction involves more than 30% of the skin, then it's called toxic epidermal necrolysis. These are life-threatening skin reactions to an antibiotic. The mortality from Stevens-Johnson syndrome is 1 to 5%, and for TEN it is 25 to 35%. Both Stevens-Johnson and TEN are immune-mediated reactions to a drug. CD8 T cells play an important role, and re-challenge with the same drug can cause a recurrence. These reactions are associated with a number of antibiotics. Sulfonamides are a classic trigger, but these reactions have also been associated with penicillins, including aminopenicillins and also cephalosporins. Another hypersensitivity reaction to penicillins is interstitial nephritis. This is an immune process in the kidneys where the drug acts as a hapten. That's a molecule that triggers an immune response. It's a hypersensitivity reaction with a complex mechanism. It is considered an example of a type 4 hypersensitivity reaction because T cells and mast cells play an important role. And if you want to read more about the immunology of interstitial nephritis, I've listed a review article at the bottom of the screen. The classic presentation of interstitial nephritis is something you should know for your exams. It involves fever because it's an allergic reaction. The inflammation in the kidneys will lead to decreased urine output. That's oliguria. The BUN and creatinine will rise. Eosinophils are sometimes seen in the urine, and then a classic finding in the urine is the presence of white cells and white cell casts. This is called sterile pyuria, because normally white cell casts are seen in the setting of pyelonephritis, but in interstitial nephritis, they occur in absence of bacteria and in absence of evidence of bacterial infection of the bladder, so there won't be symptoms like dysuria in the case of interstitial nephritis. Penicillin can also cause a hypersensitivity reaction that leads to hemolytic anemia. High dosages have been shown to lead to an extrinsic hemolytic anemia. This occurs because penicillin binds to the surface of red blood cells and leads to an immune response. Once again, the drug is acting as a hapten. The antibodies that are produced are directed against penicillin bound to red blood cells. The direct Coombs test will be positive, and this is an example of a type 2 hypersensitivity reaction. Finally, penicillin can rarely lead to a serum sickness. This is an immune complex disorder usually mediated by IgG antibodies. It occurs days to weeks after exposure because it takes time for the body to respond and produce these antibodies. Antibody-antigen complexes made up of IgG antibodies and penicillin molecules will deposit in tissues. This will lead to complement activation. This is an example of a type 3 hypersensitivity reaction. So these circulating antibodies will deposit in lots of different tissues and cause diffuse symptoms. Urticaria can be seen, also fever, also arthritis, also lymphadenopathy. And I've listed a review article at the bottom of the screen if you want to read more about serum sickness in the setting of penicillin. So as we have seen in the last few slides, there is a lot of immunology associated with penicillin, and it is very high yield for you to know this for your boards. Penicillin can cause a type 1 or acute reaction. This involves IgE antibodies and can lead to anaphylactic shock. It can cause a type 2 hypersensitivity reaction that leads to hemolysis via IgG antibodies. It can cause a serum sickness-like illness, as we talked about on the last slide. And finally, it can also lead to type 4 reactions that involve T cells. This includes the skin reactions and also interstitial nephritis. And if you understand the items I've listed on this slide, then you also understand the immunology of cephalosporin hypersensitivity reactions and sulfonamide hypersensitivity reactions. Those antibiotics can cause the same types of hypersensitivity as penicillin. And once you understand these for one class of antibiotics, you will also understand it for the others. Penicillin can potentially lead to a C. difficile infection. This will cause diarrhea following antibiotic therapy. This occurs because antibiotics deplete the normal intestinal flora, and this allows C. difficile to grow. This leads to a condition called pseudomembranous colitis. Now, this can occur with any antibiotic, not just penicillins, but some frequent associations are listed at the bottom of the screen. Clindamycin is the classic antibiotic to do this, although it's also associated with quinolones and cephalosporins and penicillins. There is a reaction that can be seen after administration of penicillin that can mimic a hypersensitivity reaction, but it is not an allergic reaction to the drug. This is called the Jarisch-Herxheimer reaction. This occurs when penicillin therapy is used to treat spirochete infections. It classically occurs in the setting of syphilis. This reaction is a febrile syndrome that involves fever, chills, flushing, and hyperventilation. It usually occurs 2 hours after starting therapy. This is not an allergic reaction to the drug. This occurs because of bacterial cell death, which leads to an immune response. So now we've talked about penicillins in general and the natural penicillins. For the rest of this video, I'm going to talk about classes of penicillins other than the natural penicillins. And the first group are the anti-staphylococcal penicillins. Drugs in this class include oxacillin, nafacillin, and dicloxacillin. These drugs were developed at a time when there was lots of resistance among Staph aureus bacteria to the natural penicillins. So this drug class was created to have a side chain that protects the beta-lactam ring from the staph penicillinases. That's why they're called anti-staphylococcal penicillins. The prototype drug in this class was methicillin, which is no longer used because it had a high frequency of adverse events, especially interstitial nephritis. These other drugs work just like methicillin without the adverse events, and they cover Staph aureus, not MRSA, not methicillin-resistant Staph aureus, the methicillin-sensitive variants of that bacteria, and they also cover most strep. Basically, they cover the same bacteria as penicillin, but they're better at covering Staph aureus because they are resistant to the staph penicillinase. So if you remember that staph and strep are often found on the skin, it's easy to remember that these drugs are commonly used for skin infections. They're often used to treat community-acquired cellulitis. This is a picture of a leg with cellulitis shown on the screen. They're also used to treat impetigo, which is a skin infection that occurs in children and causes honey-crusted lesions on the skin. It's caused by Staph aureus. They're also sometimes used to treat staph endocarditis based on culture data. You would never use these drugs as initial therapy in someone who presents with endocarditis, but once you identify the bacteria, if it's sensitive to these drugs, you will sometimes switch to one of these agents. And the side effects of these drugs are similar to penicillin. If you know the side effects of penicillin, you know the adverse events that can occur with these drugs. Our next class of penicillins are the aminopenicillins. There are two drugs in this class, ampicillin and amoxicillin, and they get their name because they both have an amino group attached to the penicillin structure. Amoxicillin is an oral drug. Ampicillin is given intravenously because it has poor bioavailability when given orally. And the reason these drugs have a broader spectrum compared with the natural penicillins is because they can penetrate the porin channel of some gram-negative bacteria. They are just as sensitive to beta-lactamase enzymes as the natural penicillins. An easy way to remember sensitivity to beta-lactamase enzymes is to remember that all penicillins are susceptible to beta-lactamase enzymes except the anti-staphylococcal, which can resist the staph penicillinase. In general, all of the penicillin antibiotics are highly sensitive to beta-lactamase enzymes. Because the aminopenicillins can get inside some gram-negative bacteria, they cover the same bugs as penicillin, plus some gram-negatives that express low amounts of beta-lactamase enzymes. I've listed on the screen some of the bacteria that are commonly treated with aminopenicillins. H. influenza is one of the most important ones. It's a gram-negative bacteria, but it's often sensitive to these drugs. Other gram-negatives that are covered by these drugs include E. coli, Proteus, Salmonella, and Shigella. The aminopenicillins are also often used to treat listeria. Now, listeria is a gram-positive bacteria, and it can be treated with penicillin, but it's often treated with the aminopenicillins so that you have coverage for listeria plus these other bacteria. So the main clinical uses of these drugs are situations where there are gram-positives and some gram-negatives that are both potential causes of the infection. So for example, otitis media and bacterial sinusitis are often caused by strep as well as H. flu, so these drugs are effective. They cover gram-positives just like penicillin, but they also cover gram-negatives like H. flu, and that makes them useful in these conditions. The aminopenicillins are also often used in bacterial meningitis, especially among the newborns and the elderly. These are populations that are at risk for listeria, so if you use an aminopenicillin, you will cover listeria and you will also cover H. flu, which can cause meningitis. You will also have some coverage for strep pneumonia. I mentioned this before, but I just want to highlight this point again. A maculopapular rash is a hypersensitivity reaction that can occur in response to penicillins, and it's most common with the aminopenicillins, and it's more common in the setting of a viral infection. And as I said before, this often occurs in the setting of an Epstein-Barr virus infection with a sore throat. Amoxicillin is given for presumed bacterial pharyngitis, and this leads to development of a rash. I also want to re-emphasize that the severe life-threatening skin reactions, Stevens-Johnson syndrome, and toxic epidermal necrolysis are commonly associated with the aminopenicillins. Beta-lactamase inhibitors are commonly used with aminopenicillins. Amoxicillin is sold with clavulanic acid, that's a drug called Augmentin. Ampicillin is sold with sulbactam, that's a drug called Unicin. And when you add a beta-lactamase inhibitor, you increase the activity of the aminopenicillins against Staph aureus and H. flu. You also increase their activity against anaerobes, including Bacteroides fragilis. So common uses for the combination aminopenicillin beta-lactamase inhibitor drugs include otitis media and sinusitis. When you add an inhibitor, the drugs become more broad spectrum and there is less resistance to therapy. The combination drugs are also often used for bite wounds, which are polymicrobial and include anaerobes. Our final class of penicillin drugs are the anti-pseudomonal penicillins. Drugs in this class include ticarcillin and piperacillin. Ticarcillin is technically a carboxypenicillin. This is its structure on the bottom left of the screen. And piperacillin is in a group of drugs called piperazine penicillins. The advantage of both of these drugs over the aminopenicillins is that they display even greater pore-in channel penetration compared to the aminopenicillins. This makes them effective against Pseudomonas aeruginosa, which is a difficult bacteria to treat and one that is usually resistant to the aminopenicillins. In general, because of their pore-in channel penetration, they have more gram-negative coverage compared to the aminopenicillins. Even though these drugs have significant pore-in channel penetration, they remain susceptible to beta-lactamases. As I told you before, all penicillins are highly susceptible to beta-lactamase enzymes. The only exception to that rule are the anti-staphylococcal drugs, and those drugs can only resist the staph penicillinase. So because these drugs are able to penetrate lots of gram-negative bacteria, but they are susceptible to beta-lactamases, they're often given together with a beta-lactamase inhibitor. Once you combine one of these drugs with a beta-lactamase inhibitor, you now have a very powerful drug because it can penetrate most gram-negative bacteria and it resists beta-lactamase enzymes. So ticarcillin is sold with clavulanic acid, that's called Timentin, and piperacillin is sold with tazobactam, that's called Zosyn. These are very broad-spectrum antibiotics. These combinations, when they're used together, they cover most gram-positive bacteria except for MRSA. They cover most gram-negative bacteria, including Pseudomonas, and they cover most anaerobic bacteria. And these are usually reserved for very sick patients, usually hospitalized patients who have sepsis or pneumonia, often due to gram-negative bacteria. And that concludes our module on the penicillins.